Welcome, everyone, to NCIHC's new podcast, Interpreting for Healthcare, Ensuring Language Access for All. I'm really glad you could join us today. I'm so excited about our guest, our very first guest, who is joining to talk about challenges from the past, present, and future in ensuring that language access for limited English proficient patients and their families. I'm really happy to let you know that our guest today is Vonessa Costa. Vonessa is currently Senior Director of Quality and Member Engagement for Healthcare Interpreter Network, a collaborative of health systems that share interpreter resources. Prior to being in that position, Vonessa was for many years the Director of Multicultural Affairs and Patient Services at Cambridge Health Alliance, named the #1 hospital in Massachusetts for health equity and community benefit by the Lown Institute in 2021. She was project lead for Cambridge Health Alliance's video interpreting initiative, honored with a 2014 Amerinet Healthcare Achievement Award for technological advances that have enhanced capacity to care for diverse patient population, over 40% of which receives care in a non-English language. And before joining Cambridge Health Alliance, Vonessa was director of Cross-Cultural Communication Institute at CCCS Incorporated, where she specialized in curriculum development for interpreter and provider training and lectured nationally on topics related to intercultural communication and language access. Vonessa is a member of the NCIHC Outreach and Membership Committee. She is a core certification healthcare interpreter, core CHI, credentialed by Certification Commission for Healthcare Interpreters, and has served as a CCHI commissioner since 2020. She's past secretary of both the Forum on the Coordination of Interpreter Services, known as FOCUS, and the International Medical Interpreter Association. Vonessa is also a graduate of the America's Essential Hospitals Fellows Program. So welcome, Vonessa. I'm so pleased that you are our groundbreaking guest. I have to out myself to the public. Vonessa and I share a language pair, which is Portuguese and English, although hers is European Portuguese and mine is Brazilian Portuguese. It has not stood in the way of a friendship that started way back when you were at CCCS and I was a supervisor at Harborview Medical Center here in Seattle. So despite the distance across the country, the connections that are often made through NCIHC and through doing this kind of work are connections that last over many years. So with a very happy heart, I welcome you and let's get started. Let's talk about the past, very much like Ghost of Christmas Past. What haunts you from the past and what do you take great pride in having achieved in the past? A loaded double-pronged question to start the conversation.
Well, thank you, Eliana. It's a pleasure to be here with you. And for two people that enjoy each other's company, we don't have nearly enough opportunities to sit and chat. So this is really wonderful. I have very happy memories of the past and of those years at CCCS. Zarita Araújo Lane was a pioneer and really a groundbreaking individual in language access in healthcare. She started the program at Cambridge Health Alliance in 1978, and I got to work in that program from 2008 to last year, 2021. But apart from that, Zarita had been my professor at Bentley College, where I studied legal and medical interpretation in Portuguese, with the first cohort of Portuguese speakers to come through a college-level training for interpreter in interpretation in Massachusetts. So I had the pleasure of learning from her as an instructor in that program, as a mentor. Together, we trained hundreds of interpreters over the years. We presented to hundreds of clinicians on best practices for communicating effectively across languages and cultures. And we got to travel the country and present at many industry conferences. And I believe I met you at an ATA conference. So it's just been it was a wonderful time came to enter the field in 1998 and to work at CCCS from 2001 to 2008. In 2008, I joined Cambridge Health Alliance as a manager of interpreter services. And I like to say, when I think about, things I'm proud of, it was Helen Keller that said, alone we can do so little, but together we can do so much. So throughout my career, I've had this wonderful opportunity to collaborate with some of the bests in our industry, to join programs that were well established and work together to make them stronger, or to join programs that had obvious weaknesses and to work together to shore up the position of the institution or the program. So at Cambridge Health Alliance, I joined an amazing team of language access leaders that included Avlo Quesam and Isabella Rocha and Fernando Gargano. And together we worked to make that program the largest and most robust anywhere in New England. CHA is a public safety net institution serving about 140,000 patients in the greater Boston area. And what's special about it is that 43% of those patients have limited English proficiency and require care in a language other than English. So what an amazing environment to learn and grow in and to build things in, an environment where almost half of the patients are going to require language assistance whenever they touch the organization, not just at all points of care, but at all points of contact. So it was really a great place to be. And when I left last year, we had grown the program to 100 staff interpreters, 50 of which were in a dedicated call center environments, and 100 credentialed bilingual providers who had been vetted for language proficiency. And so what a gift
Wow.
for a patient to receive care in an organization that had 200 people who had been vetted through different processes to help them communicate and to help meet their communication needs in healthcare.
When you first started, how many interpreters were there?
So when I first started, there were about 75 interpreters, and the call center was just being built. And so it was a very tiny team of 9 interpreters that volunteered and said, you know what, we believe that we are the best interpreters for our patients. And we believe that so much that we're willing to sit down for the first time and take phone calls from within our organization. And so that call center work setting was something that we really had a chance to lean into and to develop, and to be the first in New England to do that work inside of a hospital.
And do you still have what I call the warm body interpreter in the room, or are all of your interpreted encounters at the facility done remotely, although they are in-house?
So Cambridge Health Alliance has 3 hospital campuses, and there are still dedicated interpreter staff at each of those hospital campuses, in addition to the staff who are in the dedicated call center environments. So the day-to-day of a hospital-based interpreter is going to involve in-person and also some remote interpreting if there's a lull between in-person assignments. So yes, this is a multimodality operation that involves staff interpreters who are unionized and who receive differentials for things like national certification or multiple languages, or and what I love most about this team is that they're from the community and for the community. So some of the interpreters had the opportunity to be patients of Cambridge Health Alliance when they first arrived from places like Portugal and Brazil and Cabo Verde. And later on in their development, they had the opportunity to come back as staff and as staff interpreters. And so we have in some of our offices interpreters working alongside each other. And at one time they had been interpreter and patient, and today they are interpreter and interpreter, serving the needs of other patients. So patients have become colleagues. And so it's very interesting. They like to say we're from the community, we're for the community, we have shared lived experiences, and we're in a really good position to help patients not only with language access, but within navigating this health system and the community resources that are available outside of the health system.
And I'm really impressed with the number of vetted allied healthcare workers that have been, how is it, tested for their other than English language proficiency. When we tried to implement that at Harborview to request that providers that spoke another language take the ALTA telephone medical assessment, the first year we only had 2 allied healthcare workers willing to give it a shot. And the second year was only 9. But then the numbers really started going up. Once people realized there was a shift differential, once people realized that, yes, the test is not easy, but it is passable, and started participating in greater numbers, but it wasn't easy to get going.
Absolutely. I think one of the things that helped us at Cambridge Health Alliance was that we received funding from the Robert Wood Johnson Foundation in 2007 that led to some new processes for documenting how patients' communication needs are being met. And one of those new processes later became a tool within Epic, within the electronic health record, where providers were required to document as a hard stop how they met a patient's communication needs whenever the patient's language of care was listed as something other than English. And that tool allowed us to understand the true picture of what was happening within our organization. So most hospital departments count their interpreter services provided, and they can tell you how many they provide internally versus externally and through the different modalities. But at Cambridge Health Alliance, we wanted to understand the patient experience outside of interpreter services. So by requiring providers to document how they met the patient's communication needs, we began to learn about all kinds of communication practices that existed within the organization that we maybe weren't aware of. So in every hospital, clinicians and support staff, they're addressing patient language needs in a variety of ways. Professional interpreters, that's ideal. Bilingual providers, if they're truly bilingual, that's ideal. There might have dual role staff. There might be ad hoc interpreters. There might be practices like using untrained staff or friends and family that we consider to be concerning practices. So by requiring providers to document how they met the patient's language needs every time they interacted with that patient, we began to develop the full picture and to close the gap between what we thought was happening on the front lines and what the patient experience truly was. And from there, we were able to, in our policies, make these distinctions between what are the best practices, what are the risky practices, and begin to look at how can we do some mitigation, how can we reduce those risky practices to a minimum. And so we just developed a framework of, the best practices involve credentialed bilingual providers where the skills have been vetted, or credentialed healthcare interpreters where the skills have been vetted. And the risky practices include everything else: friends and family interpreting, unapproved bilingual staff, providers without documented bilingual proficiency providing direct care in non-English languages. All of that is very, very risky. And we were able to quantify how often this was happening and exactly where this was happening in the organization through this tracking system in the electronic health record. And so what we started to do in 2009 was to share this data in the organization, to outreach to departments and to clinicians or to service lines that had a higher than average utilization of friends and family as interpreters, and that had a higher than that were reporting that they had bilingual staff for which there was no documentation of the language proficiency. So these are two separate conversations. On the bilingual staff, it's a little more clear cut. This person claims to speak Portuguese. We have nothing in their file that indicates that they have language proficiency. We're inviting them to take a language proficiency assessment that then will enable them to, within our policies, provide that direct care, which could be an ideal experience for the patient, as long as it's done properly and the right documentation is in the file. I think what helped to move this from a best practice to a requirement was really the language in the Affordable Care Act 1557 that talked about the documentation of competencies of bilingual and multilingual staff. That's where we really got some traction in taking this from a great optional program to a required process for any clinician or clinical support person that wants to use their languages, their non-English languages, in the provision of direct care. Now, this language services documentation tool, the hard stop, it was written up twice in the Joint Commission Journal of Quality and Safety. And the second time it was written up, it included an explanation of what we did along the quality improvement front with that data. Because it's great to have data, it's great to understand the state of your organization, but then you need to use that in targeted outreach and in quality improvement. And so we were able to, as I mentioned before, to reach out systematically to areas that had a higher utilization of friends and family as interpreters. We had identified this internally as the most concerning practice, and we would look at department data on a quarterly basis. We set a threshold where we said, if more than 10% of the encounters with patients whose language of care is not English are utilizing friends and family as interpreters, then we have high risk. And we're going to reach out to that department and explore why this is happening and offer partnership in bringing this number down. And in 2012, our baseline was that we had a range of as low as 3% to as high as 24% utilization of friends and family in different departments and in different sites throughout the organization. And so when we looked at, okay, who's above 10%, who's above that threshold, there were 16 different sites that we had to reach out to. When we talked to them about why this was happening, they told us many things. They said, oh, it's because the friend or family insists. It's because it's the patient's preference. It's because we're under crushing time constraints. It's because the provider prefers this. Or we just don't know what we should do, and so we go with the flow. And so we had to do very specific interventions to address all of those root causes. One thing we did was expand our call center staffing. If you're under crushing time constraints and you want to get the best quality interpretation in the moment, then we realized we had to seat more of our own staff in the call center and expand that capacity. And in an organization that's doing 500,000 encounters a year, you have to seat a significant number of staff if you want to handle most of your requests internally. So we did some work with staffing. We started to do informational campaigns throughout the organization about the risks of using friends and family as interpreters. We launched some informational videos within the organization that featured members of the interpreter team talking to providers about best practices and illustrating the kinds of things that happen when best practices are ignored. And we started to message on the internal information boards in our top 4 languages, English, Portuguese, Spanish, and Haitian Creole. We started to message patients about the right to an interpreter and the resources that we have internally and the different modalities of interpretation. And so as patients were walking through the organization, they would see these messages pop up on the message boards. When they were sitting in a waiting area, they could read more about the interpreter services provided. But I think the biggest things we did were develop scripting for clinicians and support staff to talk about the updated policies around the use of friends and family. We were able to get the executive leadership to sign on to a policy prohibiting the use of friends and family as medical interpreters, except in emergency situations, which is very much in line with the legal requirements. And we were able to develop scripting that folks could use to talk to friends and family about this. One of those scripts went something like this. To the patients, you're welcome to bring your friend and family member into the exam room for this appointment. It's great to have someone help you out and support you. For safety reasons, CHA's policy specifies that a professional medical interpreter should be present in person or by phone or by video to facilitate any clinical communication. And during the visit, your friend or family member is welcome to let us know if there's anything that needs clarification or additional explanation. And we would travel to the different departments that had a higher than average utilization of friends and family, and we would role play this in the staff meeting. We would practice it with medical assistants. We would practice it with nurses. We would even practice it with providers, with doctors, to get them feeling more comfortable having these conversations on the front lines. And it really moved the needle. We were able to reduce the utilization of friends and family to under threshold. I think it was in 7 of those 16 sites with within, a very short period of time. So today, the system-wide utilization of friends and family as interpreters is less than 10% of all LEP encounters. I don't know if we'll ever, or they will ever get it to zero, but I think that language access and the patient experience is a lot safer now than it was when we started to do this work in 2009, and then with a lot of energy in 2012.
Well, that is such a great story of the development and the strategies used. I completely agree that giving people a chance to say it, see it, watch it, do it, touch it, feel it, before they actually have to implement a new anything, whether it's a new handheld phone in the exam room, or the cart to call the video remote interpreter, or the conversation to have when the sister-in-law or the grandson who always interprets for that family member needs to have that discussion about the fact that the professional interpreter is A, professional, and B, vetted, but C, also there for the provider. The interpreter is really there for both parties, not just for the patient. I think giving the chance to have them see and say is such a great way to help them be successful in implementing any kind of change. I know that when we first implemented video remote interpreting at Harborview, there were some areas of the hospital that were never calling us, that were always asking for that in-person interpreter. And the same strategy, going to those staff meetings, especially for the night shift people who had less accessibility to services, to bring that card around and have everybody place a test call. And it really wasn't that hard. I mean, the green button initiated the call and the red button ended the call, but still to actually touch the device and set up a scenario. What if you have a patient who comes in unaccompanied? They look Asian, but you don't speak Japanese, Chinese, Korean, Vietnamese, or many of the Asian languages. How do you determine which language interpreter that you need? Set up the kind of pitfalls that they were expecting to experience, and then having them experience different interpreters get on the line and speak to the patient until all of a sudden that patient's expression woke up when they heard the language that they understood and were able to communicate in. So hats off to making it
Yes,
easier for people to make the change. It doesn't have
absolutely.
to be as scary as it is. But I do want to round back to the beginning, which was Epic. So many hospitals use Epic, and so many people are unaware of features that can help support language access that are pre-existing in Epic. And that conversation with the IT people doesn't always go as smoothly. When I'll give another example from Harborview. When I started at Harborview, we still had Czechoslovakia and Yugoslavia as countries of origin, even though they were no longer actual countries. And we had Chinese as a language choice when we all know that there's 80 plus dialects of Chinese, and asking for a Chinese interpreter doesn't always result in an accurate match for that patient. So coming up with strategies. So we just used a hyphen: Chinese, Cantonese, Chinese hyphen Mandarin, Chinese hyphen Toisanese, all of the ones that are prevalent in our geographic area. But that
So
still took over a year
yes,
to happen
yes,
on Epic. But it's doable, people. Get the
it is.
languages
It
that
is.
you need for your demographic to show up on your Epic list.
I
And
think
the
that one of the
hard
beautiful
stop.
things, yeah, one of the beautiful things about Epic is that it can be customized. And so there's a
Yes.
lot that doesn't come out of box. It doesn't come in the basic package, but you can ask for a build. And you can even show the Epic people that Epic has done this for other hospitals.
Yes.
I'm happy to share screenshots of what the language services documentation tool looks like. I've done this in other hospitals that were first told, no, this can't be built, later had it built because they were able to show, look, it's been done before by Epic. Why couldn't it be done by Epic for us? And so there's an incredible ability to customize to the needs of your organization and to measure the things that you want to measure that are a reflection of your institutional values.
It does make it a lot easier when you're approaching IT and asking them to do something that they have not personally done before, to show them that it already exists out there in the Epic universe. And it makes the partnership that much easier, because then they know that the language of Epic, which I do not speak, is out there, and they can get that code and they can get that build from someone else who has done it and customize it. And there are so many places. It's not just at intake, and it's not just at the hard stop of authenticating what type of service was used to facilitate language access, but we can also use that for discharge information. That's come up recently on the listserv, and there are ways to customize regularly used phrases in your top languages so that that person gets a printout in their language. And then we have the stumbling block of, what if that person is not literate in that other than English language? Then we have all sorts of out of the box solutions, from asking the person to set the record function on their cell phone and have the interpreter speak the directions into the phone so that they can replay it later, to other built-ins in the system that can sometimes record. Those greeting cards we tested at Harborview before the project went over to Seattle Children's, those birthday cards that you can open and record a message, and then every time you open the card, it plays, happy birthday, mom, or whatever. They're limited to certain minute lengths. So the more expensive card that gives you more than 1.5 minutes, I think it gives you up to 4 minutes talking time, is a $4 card, but it's only $4. And you could buy 100 of those and have them available for your interpreter services department and dole them out as needed at discharge for complicated instructions for multiple meds, or difficult wound care, or discharge from the burn unit, or many other types of situations where people who are caring for their family member want to be absolutely sure and double check that they're doing this process right. They can just open the card and hear the directions again in their language. So there is a way to attack all the bumps in the road and help smooth them out. And that's one of the reasons why we wanted to launch this podcast. We wanted to be able to go to places that have come up with innovative solutions that work, and that they have metrics to show that they work. And then hopefully find people like you that are willing to share those solutions, because a rising tide lifts all boats. There's no copyright on these innovative ideas, as far as I know. I just want them to be shared as widely as possible, because they really work and they really help support the population that we have dedicated our professional careers to serve. And that's a good thing for everybody.
And
As we all
that's
know, using interpreters and having the patients and families understand what's happening to them, how to properly follow their provider's recommendations, how to properly take their medications, means reduced readmission rates, better health outcomes, less use of the emergency room as a primary care facility, and all of the things that we want to see happen.
Absolutely. And that's why I encourage language access leaders everywhere to join the National Council, to participate in the listserv. That's where a lot of these exciting conversations and ideas are being exchanged. And then to consume the podcast, to consume the webinars, and to get involved in that way. I think it's lonely work running a hospital-based language access program. You typically don't have a lot of peers within your institution. It's usually one person at the vanguard of language access and language justice with their interpreter team, if they have one. But then when you get involved through a multidisciplinary organization like NCIHC, you realize, wow, I'm not alone. These same pain points are being experienced by people like me in institutions like mine. And some of them have thought a little bit further ahead. Some of them have tried different interventions. I can do that too. They can back me up. These are my peers. I think the CCHI Language Access Leader Huddle is another great forum. The Forum on the Coordination of Interpreter Services, which is basically a peer-to-peer support group for people that run language access programs in hospitals. These are some of the venues where a language access leader can find, not just solidarity and camaraderie, but ideas for how to advance this work within their own institution.
We had a group here in Seattle called SAILS, Seattle Area Interpreter Leadership. And I encourage all of you listening to the podcast, if you don't have an area leadership group, start one. You know your cohorts, you know your colleagues in local hospitals. Invite them to meet on a phone call, on a Zoom call, once a month or once every other month, because that's the best place to share not only resources, not only job opportunities, but solutions to what I call the sticky wickets, the problems that come up over and over again, and you haven't found a creative way to put that one to rest and make it go away. Well, someone else may have. And it's that trusted group of people that are doing the work that you do, whether it's as an interpreter supervisor, manager, scheduler, uh, director of interpreter services. We're all struggling with the same things, whether it's budget, whether it's finding certified interpreters, whether it's getting compliance from the clinics and the outposts that may be linked to your medical center. All of these things have been dealt with successfully by at least one entity, and being able to share those ideas broadly just means that we're doing this work in a more consistent manner. And that also helps with compliance, a sameness of expectation, a sameness of delivery of service is reassuring in a way to people who have dealt with needing an interpreter, whether they're a provider or patient or a family member, and how they get access to that interpreter. That consistency of delivery of service is reassuring, as well as you learn from each other, fellow leaders, in terms of what has worked well and what you're still struggling with. And these out-of-box solutions come often from desperation, but they do come. And having metrics like you shared helps convince even the most resistant of providers or C-suite administrators to give an idea, an opportunity to be implemented, so that they too can see those numbers go in the direction that they want to see them go. So that was the first question about past. Let's talk now about present. You are in another part of the country. You're no longer in Southeast New England. You are where? Southwestern Florida?
Yes, I'm on the Sun
And
Coast.
and that's a very different environment, right? Southeastern New England has had robust interpreting and translation language access services, whether it's courts or healthcare or education, for quite some time, Whereas in Florida, from my understanding, both my parents are retired in Florida, the court system is pretty robust, but healthcare, not so much. So what has that been like? What is the present like in the region that you're in?
So there aren't very many robust in-house language access programs in Florida hospitals as far as I can tell. I arrived last year and I took my son to a pediatric specialty facility. And of course, when you register for the first time, they ask you what your profession is. And I always identify as a healthcare interpreter. And the nurse who was looking at this information, she said, "Oh, honey, I wish we had those." Said, you wish you had healthcare interpreters. And I asked her, what do you do when a parent or a patient speaks a language other than English? And she said, well, we call facilities and we ask them to deliver a phone, and then they bring us a phone and then we dial. And what she was describing seemed so archaic. It seemed like Massachusetts in the late 90s, before hospitals hired staff interpreters. And I've been talking to folks who work in hospitals. I've been talking to interpreters. Most interpreters in Florida do not work in hospitals, and asking more about the language access infrastructure. So I don't think Florida is alone in this. I think there's many parts of the country where lots of work needs to be done to build up the in-house language access and language justice infrastructure in a healthcare organization. I believe in the value of in-house interpreters. I don't think it's just about provider and patient choice of personality or modality. I think it even extends beyond the special ability of an interpreter to help a patient navigate the unique complexities of a particular health system. Um, I think that representation matters, and not just symbolic representation, but the physical representation at literal tables where decisions are getting made within healthcare institutions. Those tables exist in hospital conference rooms, in boardrooms, in virtual meeting spaces, but vendor interpreters don't have access to those spaces. Freelance interpreters don't have access to those spaces. Those voices are rarely heard in hospital-based conversations. And so I think that staff interpreters and in-house language access program administrators, they have an advantage in that they can literally pull up a chair, even if they weren't invited to that space, raise their voices and create, opportunities for new collaborations that result in health equity within organizations and within communities. So my goal here in Florida is to help the interpreters and translators who are already practicing in the state to make inroads into healthcare organizations. My goal is to help healthcare organizations realize that they have to begin to build language justice internally. And sometimes that starts with hiring their first in-house staff interpreter. I think we can move the needle here as well, but we have a lot farther to go than perhaps in the Northeast or in California or in other parts of the country where this work really did start 20 years ago.
Yeah, that's a big hill to climb, but there are many conference and court interpreters in Florida. Have you thought about reaching out to see if you could form a coalition of sorts, because the pool of healthcare is so small? You need some bodies in that pool.
Absolutely. So the first thing I did when I got here was join the ATIF, the Association of Translators and Interpreters of Florida. This is a division of the ATA, and it's the Regional Interpreter Association in Florida. And I put out some feelers. I posted to their wonderful WhatsApp group, "Where are the healthcare interpreters?" And I got a few nibbles, but you're right. The majority of the members currently are court and conference interpreters. So I went on the registries of the two national certifying bodies, CCHI and NBCMI, and I ran a simple search for Florida. And I realized, there's a combined 300 some odd healthcare interpreters residing in Florida,
Great.
but not necessarily members of a regional association and not necessarily working in hospitals. That's very interesting. Then I went on to the RID website and I found 600 RID certified interpreters residing in Florida. And so I thought, you put this together, that's 900 credentialed interpreters that could potentially join this effort to help healthcare interpreting become more well established in not just a few Florida hospitals, but everywhere in the state. So lots of work to be done, but lots of potential collaborators. And again, together we can do so much.
That's exciting. Is it Giovanna Lester who is still head of ATIF? I know she was instrumental in getting it started, but I wouldn't think she'd still be at the helm.
Giovanna is still an active member. The current president is Celina Romero, who is a translator and a member of the ATA, but very much supportive of the work of healthcare interpreters. And ATIF is planning a symposium, a one-day symposium in March. Most likely in Miami, focusing on healthcare interpretation and translation. And the
Oh,
plan
that's
is to
great.
make it a Florida showcase to highlight the great programs that already exist in Florida, and then to underscore the work that needs to be done and to invite potential collaborators to that work. So I'm very
Oh,
excited
exciting,
about the
exciting.
movements here.
That's really good news. That's very encouraging, and I'm glad you shared that with us.
More to come.
What else is happening currently that you're excited about before we move into the future-oriented questions?
Sure, sure. The other thing I'm very excited about has to do with my work as a CCHI commissioner. The Certification Commission for Healthcare Interpreters has just announced a new credential, CHIP, or CHI Performance. And what this is a performance-based credential for interpreters of languages of lesser diffusion, for which there has been no oral certification exam to this point. And that's a wonderful opportunity for folks like you and me who are Portuguese interpreters. And I believe that Portuguese, Russian, and Somali are the three largest languages represented in the core CHI group. But CHIP has the potential to help interpreters of all languages of lesser diffusion prove their competencies and their core interpreting skills. And so I'm very, very excited about that. There has been some great information put out through CCHI social media. Johanna Parker gave an excellent presentation about this at the most recent ATA conference, and more information to come. But I think 2023 is going to be a big year for interpreters in languages of lesser diffusion.
Oh, how exciting, particularly from my personal point of view, because there's another credential to go for. And secondly, as you said, Russian, Somali, and Portuguese, depending where you are in the country, one of those is a predominant language that should be in the top 5, most likely. Obviously, Portuguese in southeastern New England. But here in the greater Puget Sound area, Seattle, Tacoma, Somali is definitely one of our top languages. And I would imagine, I don't think Russian is still in the top 5, but it's in the top 10. And for all of the Pacific Northwest, that would also be a top 10 language. So yes, there are a lot of us hoping to add some shine to the core credential that we already have. So that's
Absolutely.
really exciting news.
Yeah. So we have the
That's
core
great.
credential that proves our knowledge. It's a knowledge-based exam. We have our language proficiency assessments that prove our proficiency in the languages themselves. But what was missing is the performance-based interpreting exam. And so what this is a monolingual exam that anyone can take that assesses the cognitive interpreting abilities. And it's a novel concept. If you're interested in learning more, there's a lot of information on the CCHI website. But it started with the National Task Force, and they produced a white paper in 2020 that confirmed that this monolingual exam really does measure what it sets out to measure. And it has a statistically significant corresponding correlation to the bilingual CHI exams. And so I think in practical terms, this will be a way for an interpreter like myself to say, look, I have all of these other pieces of the portfolio, and now I have this performance-based exam. And to approach the employer, whether that's a language service company or a hospital, and say, could I be compensated based on this portfolio that now includes a performance-based exam. Could I get that certification differential that my Spanish interpreter or Arabic interpreter or Mandarin interpreter colleague has had for quite some time? So very interesting to see. I think, like you said earlier, the rising tide lifts all boats. I think this will help lift us up in terms of patient safety, but also lift up the interpreters of languages of lesser diffusion, and help them get, compensation to their skill, and also help them, you just have that pride of saying, look, I took a performance-based exam and I aced it.
That's that's really like the best piece of news that has come up in this entire podcast. I'm really excited about it.
Well, that's what I'm most excited about for the coming year. So I'm excited, as I hear, what's gone into creating this exam. I'm excited when I hear the announcements that it's coming out, and I look forward to being able to take it and to prove my core interpreting skills to myself again.
You and me both. Well, this brings us to the last question, which is, what are you most excited about, or what are you most worried about, both sides of the coin, looking to the future? I know offshoring is a concern, and I know that this new credential is something to be excited about, but what am I missing?
So I think you know me well. I am most concerned about the trend of hospitals eliminating or downsizing their in-house interpreter teams, because when you do that, you eliminate or you weaken your most powerful language justice advocates. At Cambridge Health Alliance, just going back there, the interpreters got involved in so many amazing multidisciplinary projects that were just outside of interpreting, but really had impact on health equity. One of the ones I'm most proud of, and it continues to this day, and you can check it out on Facebook, is our Portuguese language and our Spanish language social media pages. So in 2019, CHA decided it needed to engage with the Portuguese speaking communities on social media. And we worked with the interpreters to create CHA Saúde, which is basically a Facebook page that Portuguese speakers can follow, not just for information about CHA and its services, but for health information. And so for 2.5 years now, they've been putting out information that actually contributes to the health of its followers, to the health of the local community. That work is being led by CHA's in-house interpreters in connection with the marketing and the communication departments. Last year, they decided to branch into Spanish, which is our second most requested language and our third most spoken language in the organization. And they created a similar page called Salud es Vida. So things like this are not going to happen in institutions the way that they can when you have staff interpreters involved. And so I think about this a lot when I hear that a hospital has laid off its team or downsized its team or outsourced its whole program. Who's walking through the halls of the hospital pointing out risky communication practices? Who's coaching providers in best practices for safe communication? Who's doing that language justice and health equity work? Who's monitoring, the practices of today's care teams and helping to coach the clinicians of tomorrow? So I think that's the biggest thing that I'm concerned about is, let's continue to build up language access infrastructure and language justice infrastructure in hospitals everywhere in the US, drawing talent from local communities, because who is healthcare interpreting for in the US? It's for the local immigrant populations that we serve. And I think sometimes the best advocates come from within those communities, and can be trained and can be employed by hospitals as healthcare interpreters, but also as health equity champions and health equity catalysts.
It's that friendly bridge for the LEP patient or their family member that may have a concern, but would often never go to patient relations or the complaint department, whatever it's called in your hospital, on their own, but would be willing to voice that worry or that concern to the interpreter. And the interpreter would often say, do you want me to walk with you over to patient relations so that you can tell them what's happening and I can interpret for you? And
Mhm.
then that miscommunication or that misunderstanding doesn't grow and become larger. It gets handled right at the beginning, right where you can nip things in the bud before they actually turn into a problem or a negative outcome. And that's
Absolutely.
really missing when you work remotely, whether you're an independent contractor with your own clients or you're working for an agency that has a contract with the big charity hospital in town and you're taking those calls at home, there's no way for that independent contractor to give feedback if they witnessed something negative or if they have a contribution for, hey, that would solve this bottleneck. There's really no way for them to contribute those ideas or their thoughts. Some agencies have a very quick way for the provider to give the interpreters whose service they utilize 1 to 5 stars at the end, a little satisfaction rating, but there's very little exchange about how well did this encounter work for you when it's remote and it's not tied to the facility. And that's a
Absolutely.
concern. That's where things can, the cracks get bigger and things, bigger and bigger things start to fall
Yeah.
through those cracks. So
And OPI and VRI remote interpreters, they may have a supervisor within their language service company, and they may feel that they can share their experiences with that supervisor, the good, the bad, and the ugly. But as a hospital-based coordinator of language services, I have to tell you, having worked with many, many vendor organizations, never once did that feedback make it to me. Never once, as a hospital-based language service coordinator, did I get feedback from the language service company saying, our interpreters are concerned about practices in that department, or about how this clinician interacts with their patients, but I got that feedback from staff interpreters every week, if not on a daily basis. If you can't name it, you can't fix it,
absolutely.
right?
So
And so
this would be one suggestion for people who are managing these programs and you don't have an in-house staff. You should ask the vendor who is providing the services for a portal, for a way for people to communicate bottlenecks or issues so that they can be improved. Otherwise, they just get glossed over and then it grows and becomes a big enough problem that it could end up in court, that it could end up costing the facility money. Why let it get to that point?
yeah. Interpreters, whether staff or external, whether in person or remote, they are literally or virtually walking through the patient experience with the patient. They are most qualified to speak up and say, this is concerning, or this is good. But when you don't belong to an organization, it's very hard to raise awareness about concerning practices in any meaningful way that makes it back and has the potential to effect change within that organization.
I think that's the biggest stumbling block to outsourcing all of your staff or relying completely on an agency is not asking that question of how do we have information flow back and forth so that we can continually improve and not just tick the box and say, yep, we got an agency, we're done. We don't have to worry
Mhm.
about language access
Yeah.
anymore. That's not how it works.
Yeah. And interpreters living within a community and perhaps working with a local agency, they might find other ways to give that feedback as patients, as family members of patients, as community members. But the farther you get from the organization geographically, the bigger the divide, the bigger the gap that's very hard to bridge.
So that's the big concern. We can work at trying to get the people who hire the vendors to be more aware of the fact that there needs to be dialogue when issues are run across, because as you said, the interpreter is walking a mile in that patient's shoes or alongside that patient. But what else? What else can we do to help support the fact that there should be at least a small, vibrant core of in-house staff?
So I think what we need to do is to get in front of clinicians and hospital administrators, to get in front of the patient safety professionals, to get in front of the compliance professionals, to attend and present at their conferences so that they come to understand these issues the way that we do. Uh, when I attend conferences of, for example, the American Medical Association, or America's Essential Hospitals, I see language service companies present as vendors and exhibitors, but I don't see a lot of language professionals on the agenda as presenters. And so we really need to get into the conversations within the associations where these conversations are happening, not just to promote a product or as sales professionals, but as teachers and instructors and coaches, and really have a call to action. And I think we need to do more of this work as well as providers are being trained. We need to get into the medical schools to get onto their curriculum so that the providers of tomorrow know more about healthcare language access than the providers of today.
I agree. I tried very hard when I was with a company called In Demand to get our sales staff to do a little bit of training with providers on how to partner with interpreters rather than just how to turn on the machine, right? There's two pieces. How do I use the technology? But then how do I work well in this triadic encounter, even if the three of us aren't all in the same room? Um,
Yeah.
we
And
ended up
again,
creating a booklet that was given to providers, but that's still not as efficient as the see it, touch it, feel it, demonstrate it experience prior to then actually working with an LEP patient and an interpreter.
yeah. And the reality is that most of that training, where it gets done, is being done by interpreters and by language access administrators in hospitals, which is another reason why we need to retain those positions in hospitals. We take them out, and then there's even less coaching and less instruction and less guidance for the clinicians on how to care more effectively for patients.
So I think our conclusion is hospitals, you cannot totally eliminate your staff interpreters, not only because of the service that they provide, but the local knowledge, the tribal knowledge of the community, the culture of that hospital, the people that come there to get health care, the providers that work there to treat those patients, and how everything works together. They are the canary in the coal mine. And if you get rid of the canary, we could have some very negative consequences that could have been prevented by having that alert system in place. Now, I think second to that is what you said. Their language service providers and agencies are present at the provider and hospital conferences. We as trainers, we as interpreters ourselves also need to be part of that conversation. It's too easy to gloss over and go to the shiny equipment and see, what your broadband upload or download speed is. But really what is key to all of that, to making all of this work, is having that interpreter that understands the community that this hospital and this patient are living in, and understand the cultural divide that we are trying to bridge, not just with the words that get interpreted from one language to another, but with the knowledge of all those cultural bits that are coming into play.
Absolutely. And then I think the other thing that's needed, and not in the distant future, but soon, is more research. If it is more expensive, at least on paper, to have in-house interpreters or staff interpreters handling most of your interpreter request volume, well, then how do we quantify the return on investment? Um, do patients do better? Are their outcomes better when the interpreters are local? Are the outcomes better with one modality over another? This really has not been researched. We don't really have any evidence one way or the other. And so I think that there's opportunities for interpreter associations or multidisciplinary organizations like NCIHC to partner with medical associations or with other health professions to do this kind of research that will give us clarity as we forge a path ahead.
And I do want to say to any listeners out there, if you are aware of this type of research being done, please get in touch with us.
Yeah.
Because we need to push this forward with everything that we've got in order to make sure that language access for patients in healthcare continues to improve and expand rather than to become frozen in time or in some cases retreat to a less satisfactory and lower quality model.
Mm-hmm. At CHA, we had internal studies that showed that provider satisfaction was higher when we answered more calls in-house. And when we answered fewer calls in-house, the satisfaction decreased. And we went to finance with that data and they said, well, provider satisfaction, doctors want lots of things we don't give them. They want lots of things we can't give them. So it has to be more than just satisfaction surveys. We have to look at health equity and we have to look at health outcomes to really quantify the return on investment in building your in-house language access program.
Yep, those length of stay numbers and readmission rate numbers really are impactful. So we must be diligent about collecting them, as well as that preferred language at the very first contact for every patient. Is there something that you would like to speak on that I failed to ask about, Vanessa?
Well, I think we've run out of time for a conversation that folks will actually listen to, but I look forward to continuing this conversation with folks who listen to the podcast, with you one-to-one, and I hope that we can get volunteers to partner on some of these initiatives that are so needed in healthcare language access today.
Yes, so please, if you can think of someone that you would like to suggest as a speaker, if you have a research project that is currently underway, collecting the kind of data that we talked about, if you have some ideas that were not shared here that have borne successful fruit, please contact us at trainerswebinars@ncihc.org. That's trainerswebinars@ncihc.org. So thank you everyone for joining us today for our inaugural podcast with NCIHC. Thank you so much, Vanessa. The breadth of your knowledge and experience can only benefit everyone who listened today. I look forward to a part 2 in the future where we can maybe come back with some answers to the questions that we posed or some ongoing research that we are looking for additional participants in order to get the numbers that we need to move that needle. And stay tuned, folks. There are many more of these in the can waiting to be released to you. Thank you, Vanessa, so much for joining us today. Thank you, audience members, NCIHC members, and non-members alike. And stay tuned. Next month, there will be podcast number 2. Bye, everybody. Thanks for
Bye-bye.
being
Thank
with us
you.
here today. Ciao, ciao.